I wish you all a very good afternoon from Mumbai. And in my next 10 minutes or so, I'll try and talk about DPP4 inhibitors, how safe they are, and how beautiful they are as the drugs. Now, probably Dr. Parikh, Dr. Sachin, and KD sir has beautifully elaborated various roles of various drugs. So here I am talking to you about the role of DPP4 inhibitors. These are my disclosures. And as Das sir was talking about the progressive nature of type 2 diabetes, and this is the slide that we have seen in most of the conferences, I still would like to bring your attention that there is one area which probably did not get that much of attention, what it actually deserved till around last decade or so, and that is an incretin effect. Because we all know that the endogenous GLP or exogenous GLP have so many beneficial effects. No matter it can come to the glucose dependent insulin response of the beta cells is concerned, or the reduction in the prandial glycemia is concerned, or weight reduction primarily secondary to the slow gastric emptying and increase in satiety is concerned, or probably the anti-inflammatory or other additional cardiovascular benefits these drugs have to offer. So we had researchers thinking about to have a prolonged effect of the endogenous GLP, which gets secreted into the duodenal K cells and L cells. So one idea popped up that why not to stop this premature destruction or an early destruction, which happens primarily by an enzyme which is called as dipeptidyl peptidase 4, or we popularly know it as DPP4. And that's how the concept of DPP4 inhibitors not only emerged, but last 1.5 decades, we have used these molecules extensively. And that is the place in the ADA 2019 guidelines that DPP4 finds that right after lifestyle change and metformin therapy, probably DPP4 is one of those drugs. And why it is important? Because we know that we choose the drugs where they are not only glycemically efficacious, but they may have a synchronized action. They should have a beta cell protective effect. There should be a durability of the effect. Hypoglycemia should be lower, and there should be a additional cardiovascular safety. So from a glycemic triad of just HbA1c reduction, fasting and prandial control, now we have moved to glycemic hexad, as Dr. Das usually teaches us. Is this, and now we have changed our outlook of looking at the molecules with additional weight benefits, cardiovascular benefits, and low hypoglycemia. And DPP4 stands right exactly there. Now, being not only oral, they are effective, very well tolerated, safe, weight neutral, and cardiovascular neutral. And we have in India around 7 DPP4 inhibitors which are already available. And now, with the patent of vildagliptin getting revoked and teneligliptin in the market, while the cost caveat, which Dr. Das sir was so sensitive and very specific about, has been beautifully addressed by these drugs as well. And you can clearly see the glycemic efficacy, which is evident. And depending on the glycemic status of the patient, the efficacy of the drug changes. But you can see that even at the HbA1c of around 8, it still causes an HbA1c reduction of around 0.5 to 1.5%. And it's not only just effective as a monotherapy, but as in combination with either metformin or in a triple drug combination with sulfonylurea, it is equally effective. And it has got a durable effect. You can see that clearly. This is the study which has been done by DeFranzo, and he has shown that over a period of around 4 years' time, the glycemic efficacy persisted. And what is most interesting, and this is again a paper from Dr. Kamlesh Kunti and the team, which was published in New England Journal of Medicine, where they have shown that whenever you are using gliptins, you hardly require a quick, stepping up or escalation of the therapy as far as the diabetes is concerned. Now we also talk about glycemic variability in time in range. You can see that gliptins have an ability to reduce glycemic variability to a tune of almost 30%. Now 30% may not strike you here, but what if I say that 1 in every third or fourth patient is benefited? That is phenomenal. Now when we talk about the drugs, we talk about the cardiovascular protection by rule. And this is the evidence which has been generated by enormous publications happening through various DPP4 cardiovascular outcome trials. And we all are aware about it. And latest Carolina, as Das sir was alluding to, has also shown that DPP4 are reasonably safe drug as far as cardiovascular outcomes are concerned, even in the high-risk cardiovascular patients. Additionally, DPP4 inhibitors, they do not have the increased risk of myocardial infarction, which probably rosiglitazone has shown an indication, or probably stroke or any cardiovascular death. And there were mixed signals for heart failure, especially after severtemy, but then that is adequately addressed by recently published data as far as Carmelina and Carolina is, that there is no heart failure worsening, and the real world evidence which has come from Korea and China, they have shown that they are fairly fine. Renal safety, absolutely safe. We know that these are the molecules because we know that GLP-1 independent mechanism of DPP4 in diabetic kidney disease has an established role to play, and where the soluble DPP4 part of the enzyme has got a more role to play in membrane and also the membrane bound. So whenever you use DPP4 inhibitors, really they do not only offer the renal safety, but also offer you the renal protection. And we can see here the drugs like linagliptin or phenylagliptin, even in the moderate to severe to up to end-stage renal disease, do not require a dose adjustment, and most of the DPP4 inhibitors are fine with just one-stage dose adjustments. And Carmelina, as Sir was talking about, is a beautiful example where they have shown that it not only protects but also improves the renal function over a period of time. Interestingly, DPP4 has a potential to have an anti-hypertensive effect. And look at this. This is a new data which is coming up. And the data from all the human and the animal models, you can see that DPP4 inhibitors have a potency to reduce down the systolic as well as diastolic blood pressure through what? Prominently acting on what we call it as an NHE3 isoform exchanger, which is actually responsible for the sodium reabsorption at the proximal tubular brush borders. And that's how probably it reduces down blood pressure. And there are additional mechanisms like immunological mechanisms, vascular mechanisms, neural mechanisms, and hormonal mechanisms, apart from the renal mechanisms, which actually offers blood pressure reduction when you are using DPP4 inhibitors. As far as hepatic challenge is concerned, we all are aware that from in child's class 1 and 2, where there is a mild to moderate hepatic dysfunction, except vildagliptin, which is not really recommended. Most of the gliptins otherwise are proved to be very, very safe. In the severe hepatic dysfunction, of course, no OHA can be used at all, and there you need to only use insulin. So you can see that if at all you need to use DPP4 inhibitors, there are technically no drug-to-drug interactions. No matter it could be a simultaneous antidiabetic drugs, antihypertensive drugs, or the drugs which get metabolized through CYP354A pathway. These drugs, they do not cause any drug-to-drug interaction with DPP4 inhibitors. Lastly, I'll talk about DPP4 in COVID-19. We all know that in COVID-19, again, along with the increased expression of ACE2 receptors, which actually is responsible for the adhesion of the COVID virus and its entry into the cell, but also there is a rise in the soluble DPP4. And by using DPP4 inhibitors, and you can see here where my arrow is, they have shown that gliptins especially can be protective to weather this storm of cytokine, which happens primarily because of the various aspects of the COVID pathology. So if I have to finish, I'll tell you that gliptins are so wonderful drugs. So my 10 commandments for gliptin use, as they are oral, compliant, effective, no mealtime caveats, weight neutral, no adverse events. They are absolutely affordable, they are reno-safe, they are comparable, and they do not have any drug-to-drug interactions. So if you look at the various OHA or the anti-diabetic armamentarium and the profile of these entire drugs, look at the DPP4s. Everything is almost in blue. Hardly there is small yellow, which actually raises your prawns. So in omnious octet of diffranzo, you will see that DPP4 inhibitors, they work nearly at 4 or almost 5 axes. So patients on DPP4, everything, when you consider the factors like age, duration, efficacy, comorbidities, weight, cost, hypoglycemia, everywhere, DPP4 inhibitors really bring smile back, not only the patients, but also to the clinicians. So lastly, let me say that do not ever forget the safety of the therapy, as our Hippocrates has taught us, is we need to follow primum non nocere. Rule number 1. Rule number 2 is, if possible, then do good, that is primum superior. Thank you very much for your kind attention. I appreciate the I would say opportunity, and thank you very much. And I wish that I would have been physically meeting Dr. Tiwaskar sir and Dr. Das sir. Good afternoon, Tiwaskar sir. Namaskar Gato. Thank you very much.